Good afternoon, everyone. This is May 23rd, 2026, 12 p.m. Eastern. And we are here to have this awesome webinar with our awesome speakers and panelists. Before we start the webinar, I am thrilled to share a news with all of us because all people over here, our speakers, our panelists, they are here for international trained physicians and international medical graduate, and they themselves being like as an international medical graduate and ITPs, internationally trained physicians. We are all advocating our ITPs and IMGs. For last few years, I was reaching out to the legislative about this 100,000 bill and shortage of the physicians and sustainability of private practices. And I've been writing letters to Congressman McGovern, Ed Markey, and other senators. And on April 22nd, I was given an opportunity by the Congressman McGovern to have a one-to-one meeting with his senior advisor, Isabella Addo. And I talked about these concerns, and I requested him to co-sponsor HR 7961 Act. So I received the email from his office that he co-sponsored it, and I'm sharing this email with you guys that I received this from his office, that he is co-sponsoring it and he signed it.
Oh my God.
Yeah. Oh, that's a good news.
It's a big news.
On the congress.gov. Soon it will be there.
Congratulations.
Good job.
That's I wanted to share. I wanted to share. This is a huge thing. And this is the email I received. So I wanted to share with you that this is what we all do. This is what we all, striving for our IMGs and ITPs. And, all you, Dr. Humayun and Dr. Abraham, Dr. Alam, Maria, and Harun, we are all like, I'm really, you guys are all the mentors, and you guys are there for our ITPs and IMG, and we will be having a better future for our IMGs. So this is what I wanted to share.
Good job. Congratulations.
Thank you. So now we will start our webinar. And something about before, we go to our first speaker, Liaison Committee APPNA is very humble and proud to announce that we were able to successfully engage more than 4,000 ITPs and IMG through Liaison Committee with a very educational webinar in last 3 to 4 months in collaboration with our outstanding keynote speakers to provide transparent, authentic information to our ITPs and IMGs in regards to evolving credentialing and licensure about alternate pathways without residencies and major USMLE changes in 2026, and how to become a part of an organized medicine to amplify our voice, to support and advocate IMGs, and to bring friendly policies for the IMGs. It is also an effort of the Liaison Committee APPNA to keep our ITPs and IMG well informed about evolving healthcare system in USA, and also protecting the ITPs and IMGs not to fall into the trap of falsely claimed recruiters and agents who are telling them that they can get them a job, taking so much money from them. And it is a very complex web, and IMGs are falling for it. So I promise this to myself and other people that we're gonna put something together to bring the right authentic information to all these ITP. And I reached out to Dr. Humayun. He said, I am on board. Then I was reaching out to other people. And I'm so thankful to all of you guys that whoever I reached to, they said, yes, we are on board. We want to help all these ITP. We want to convey the right message to them, for their safety and for their academic, journey. So I'm very thankful about that. And today, our message is to all these, ITPs and IMG to follow these guidelines through FSMB and our authentic speakers from different state medical boards and medical societies to get the right information. Today, we have another excellent, most important healthcare topic for our APPNA physicians, professional development, which is appropriate use of artificial intelligence by clinicians and healthcare workers, and specific medical regulations about its use and role of FSMB. As we all know that artificial intelligence in healthcare is governed by overlapping federal, state, and international frameworks that focus on safety, privacy, and accountability of patients and physicians. The panel discussion will be centered to discuss the Federation of State Medical Boards to thoughtfully and transparently discuss innovation in healthcare while keeping patient safety and public protection at the forefront of these conversations. This topic will be presented by our own Dr. Humayun Chaudhry, who will be the keynote speaker in this topic. And he is a DO, MACP, FRCP London, a graduate of NYU NYIT College of Osteopathic Medicine, Howard Chen School of Public Health, CEO and president of FSMB. From 2016 and 2018, he was chair of the International Association of Medical Regulatory Authorities, past president of the American College of Osteopathic Internists. Dr. Humayun, thank you so much for your leadership and unconditional help for all the physicians and all your time in putting this together for us. And now Dr. Humayun will present his slides to us, and afterwards we will talk to him.
Thank you so much, Dr. Rafia. Hopefully everybody can hear me, and we are delighted, both Dr. Abraham and I, to speak to this gathering on this webinar. And thank you for including us, because this is, I think, my third webinar. What we're going to do today is talk a little bit about AI, and then Dr. Abraham will talk a little bit more and give an update on what's happening with internationally trained physicians and some of the legislation that is making its way through the states. So I'll ask, unfortunately I'm in a car, my wife is driving, I'm the passenger, so, but I'll ask Dr. Abraham to share the slides for me. So
thank you, Dr. Abraham.
And then we'll get started.
They are being shared, Dr. Chaudhry. I don't know if you're able to see them.
Yep, I see them. Okay, so if I could ask you to go to the next slide, George. Okay, so a little background about the FSMB that I'm sure most of you know, but the FSMB represents the nation's state licensing boards. We are not involved in specialty boards. We are the licensing bodies for all 50 states and the territories. We were founded in 1912 by the state boards themselves, and we serve our member boards whose primary mission is to protect the public. Next slide, please. So this is a snapshot from a recent House of Delegates meeting of the Federation of State Medical Boards. I will mention that it's an open meeting. People are welcome to register and attend the meeting if they want to. And we're quite democratic when we vote on policies and other matters related to the organization. Every state medical board gets a vote as a delegate, and we discuss policies, we discuss licensure, discipline issues. We also discuss the USMLE, which is a service that we have in partnership with the National Board of Medical Examiners. Next slide, please. So just to give you some background, you may know this already, but every 2 years, the Federation does a census of all of the physicians who are licensed in the United States. We do this every 2 years. We're in the process of putting together the current one right now. And so, of course, because we have this partnership with all of the medical boards, we know exactly how many physicians there are. We know where they went to medical school. We know where they did their specialty training. We know what they are specially certified in. We know where they are licensed, and we know if there's been any disciplinary action taken against them by any of the state licensing boards. We also have agreements with many countries, and so we increasingly have information from and about physicians who are also licensed in other countries. But in our last census, at the end of 2024, there were exactly 1.08 million physicians, MDs, DOs, people with MBBS degrees, etc. The vast majority, 89% were MDs, 11% were DOs. That's a growing number. Next slide, please. So as Dr. Rafia said, the role of the international medical graduates and internationally trained physicians is very critical and vital to the United States and its ability to deliver care. Among that 1.08 million physicians that we have, they come from 171 countries, 2,392 medical schools. The top 5 countries or regions from which international graduates come from include India, Pakistan, the Caribbean region, Mexico, and the Philippines, but they come from all 171 countries around the world. And so that's important for us to know. It's important for our legislators, both at the state and the federal level, to know as well, especially as we try to get exceptions for healthcare practitioners who are, there's increasingly restrictions, as you know. Next slide. So as we talk about artificial intelligence, many of you know AI has been around quite a long time. It was actually first coined as a term back in 1955. That's a long time ago. But obviously a lot has changed since then. Some of you may recall the movie 2001: A Space Odyssey, where AI became popularized when there was a robot essentially that knew a lot more than just computer skills and data and knowledge. But really, AI, as you know, entered the public stage, in November of 2022, when OpenAI released ChatGPT as basically a chatbot that anybody could use for free. And that has led to many, many hundreds of millions of people engaging and using with AI, as well as not only physicians, but also patients. We're currently in 2026, they're saying that we are living in the age of agentic AI, the year of agentic AI. And that's important because agentic AI is more than just giving you facts, able to do much more. Maybe for a physician's practice, for example, it is an example of setting an appointment with a consultant, scheduling a procedure, and not just being the taskmaster. So I think that's starting to happen, and we'll see more of that happening in the future. Next slide. This just shows you how quickly AI has grown. When the internet was first introduced, it took about 12 or 13 years to get about 800 million people involved in using the internet. ChatGPT took about 2 years to reach that mark. So clearly people are attuned to it. People have technology. Many people around the world, smartphones and laptops and desktops, and ChatGPT and other AI platforms are growing in number and usage, and they are ubiquitous. Next slide. The current uses of AI, many of you know, include everything from ambient documentation, which appears to be gaining ground across the country. Most of the electronic health record platforms like Epic use it and have it available. It's also being used as a clinical decision support tool, especially for complicated cases. I'm a general internist myself, and so there are more than one occasions where a complicated or a difficult case can come across an internist, and this can be a very helpful tool to give you some additional ideas when it's not straightforward. Dr. Abraham probably will say the same when it comes to infectious diseases, his specialty and his area of expertise. But also patient communication, virtual triage, also insurance and administrative appeals, and of course it's being also used for prior authorization. That's a different matter, but it is being used throughout in AI. Next slide. Of course, as AI is beginning to be used, physicians need to be careful. So some of you may have seen this. In California, we have an example of a situation where a patient went to the doctor, and the doctor used ambient documentation for the encounter. Afterward, the patient alleges that she was not informed that AI was going to be part of the conversation and that ambient documentation was being used. And so she is suing the doctor and the health company that employs the doctor because she is saying that her personal information was shared by a AI platform and potentially shared with lots of other people as well without her permission. Now, the doctor claims that the patient signed a electronic authorization, that she understood that this was augmented documentation, but the patient denies it and said, I never signed that, I never saw that, no one explained it to me. So just as an example of things where doctors are going to have to be more careful and make sure there is transparency in that encounter with the patient. Next slide. So I'll give you some examples of how AI is already being used in a number of specialties. This came out just last month in the Journal of the American College of Cardiology. They looked at 200,000 EKGs and determined that there is a way statistically significant where you can use just a standard 12-lead EKG to predict the risk of long-term ischemic stroke and that this is very similar to the Framingham type of tables that we typically use. And it's an example of how there are things that AI can see that the human eye cannot see when they read a 12-lead EKG. And it's an example of how I think AI will be an important cognitive support tool for physicians in their practice. Next slide. So another example of where AI can be helpful is another example in cardiology, and that is that in the detection of congestive heart failure with preserved ejection fraction. There are subtleties on a 12-lead EKG. Again, a 12-lead EKG, something we do all the time, we read all the time, the human eye, but with AI, we can do that much more in terms of risk stratification, rather than doing many additional tests, spending a lot of money. This is an example of using AI cost effectively to screen for diseases. Next slide. So just to give an example, these are your typical EKG findings of heart failure with preserved ejection fraction. These are not easy to do with the naked eye, but with AI, all these things can be quite detectable. So for example, when we do a 12-lead EKG, we typically look at the QRS axis. But what the AI can do is simultaneously, you can look at the R wave axis, the T wave axis, the P wave axis, something that ordinarily is not taught to medical students or even cardiology fellows to figure out, but is an example of how AI can be so useful. Next slide. Another example is in the world of gastroenterology. Next slide. If you think about capsule endoscopy, for those of you who engage in small bowel capsule endoscopy, you know that this typically for thousands of images, more than 10,000 images typically. It sometimes takes as much as a half an hour or more for the gastroenterologist to go through those images to figure out which are the most important ones. AI can do that in 3 minutes, for example. So that's another example of where you can use thoughtful cognitive support, cognitive offloading to support your practice. And I think these are the types of activities that I think are good. I don't think anyone can, you have to make sure that these tools are defensible, that they're backed by science and evidence, but these are certainly emerging and many of the specialty colleges are looking at them as well. Next slide. Certainly precision oncology is another area. Again, these are very recent articles that are coming out. This is from the journal, you can see my phone here, Digital Medicine, looking at the convergence of evolving AI and machine learning techniques, precision oncology, helping you decide which specific chemotherapeutic agent to use and at what dose, for example, that is specific to the patient. Next slide. So if you look on the left side of this slide, cognitive offloading is a term that was defined about 10 years ago, even before ChatGPT. The notion of a physician, in this case in healthcare, deciding to allow AI to do some of the work that they do to enable them to be more effective and reduce their cognitive demands so they can focus on what matters. And I think nobody has a problem with the left side of the screen. Cognitive offloading can be quite good and can help with clinician wellness and maybe even give you more time to spend with the patient. The challenge for healthcare, as well as for medical regulation, is the right side of the slide. Cognitive surrender. How much do you give up if you start to use artificial intelligence more and more? And I think that's where the challenge lies, not only for the practice of medicine, but also for medical regulators. Now, this could be a great area. There could be some elements of cognitive surrender that a physician does, but can a physician completely give up the practice of medicine and allow a machine to do that? I don't think the technology is advanced at this point to practice medicine on its own, but this is what worries ethicists and it worries medical regulators as well. Cognitive offloading is fine. With surrender, questions about what if there's harm, and if there's harm, it's important that we just figure out who is responsible. Next slide.
Avoiding harm to underserved and underrepresented communities.
No, thank you, Dr. Abraham. So with AI, one of the challenges is that the data, AI is not doing thinking. It is looking at the data that already exists And if the data is biased, then the result that it shares with you or the suggestion that it gives you will also be biased. And this is particularly a problem with the data that comes and how it sometimes does not reflect what is seen in underserved and underrepresented communities. So one good example of this is AI being used for skin cancer diagnostics have shown significantly lower performance for people of color because the original data set is based upon people with lighter skin, for example. The NAACP, the National Association for the Advancement of Colored People's 2025 white paper, Building a Healthier Future, is a good document that talks about the dangers of using AI and extrapolating the data to your population for general population. I think we need to be careful of that. Next slide. So the FSMB, the Federation of State Medical Boards, has been looking at AI for a number of years. Dr. Abraham has been on our board for a number of years. He knows many of the conversations we've had. And we weren't really ready to issue any guidance until 2024, when our House of Delegates got together and adopted recommendations from our Ethics and Professionalism Committee. I'm not going to go over our document, but if you wanted to go to our website, fsmb.org, you can find the entire policy. It's not very long. It's about 10 pages long, but it's guidance for physicians and it's guidance for state medical boards. But here are some basic important points that I've highlighted in this slide. Essentially, if you choose to use AI, and we welcome your use of AI, you shouldn't be afraid to use AI. You should be thoughtful about your use. If you do that, you accept responsibility for responding appropriately to the AI's recommendations. In other words, your defense cannot be, well, I made a mistake because AI told me to. At the end of the day, the physician, the human physician, is the individual who is responsible. Remember that state medical boards license humans, they don't license machines. At the same time, if you choose to follow the course of treatment that is recommended by an AI generated response and you agree with it, that is fine. You can do that, but be prepared to provide a rationale for that and document that in your decision making. It's important that if there's a problem, retrospectively, we can figure out and people can figure out why you chose the decision. And just saying that AI told you to do it is not adequate enough. You want to make sure that you are thinking aligned with AI. By the same token, if you disagree with AI, which is perfectly acceptable and may be appropriate, that should be documented as well, because there may be a situation where most doctors use AI for a particular situation. You feel because of your expertise or knowledge that it's not appropriate for your patient, and that should be documented as well. Next slide. So I'll finish up with these last two slides. There's some interesting things happening in our states. These are not necessarily things that are happening because of state medical boards, but I'm giving you a couple of examples of what's happening in some of the states. In the state of Utah, they have a couple of interesting experiments that the state is allowing for automated refilling of prescriptions. There's a company called Doctronic. There are a couple of other companies as well that has gotten permission from the state of Utah to allow physicians to use their tools and their service to automatically refill prescriptions without any input from the doctor. This is quite unusual, quite different, of course, and we'll have to see how this experiment, which is really what this is, there are safeguards in place, but we'll have to see if this is an example of cognitive support and cognitive offloading that can be helpful. Next slide. This is my last slide. This is even more radical. In states of Idaho and Iowa, a legislative bill was introduced, almost identical in language in both states, that for the first time would create a licensing board for machines, specifically an autonomous service provider who could deliver care without any human interaction. This was not just conceptual, it was quite detailed. The legislation talked about how many people should be on this board, what types of individuals should serve on this board, and literally be allowed to practice medicine completely independently or autonomously. the legislation did not pass. It did not make it out of committee and failed because I think it's too premature. But it's an example of how the industry is pushing more and more to allow more to occur. So the state boards are monitoring this and watching this, and we're going to be having conversations. In fact, this year, our new chair, I should say, Dr. Christy Valentine Thayard from New York, will be putting together an AI work group to look at everything that's changed in 2024. So with that, I'll stop. Thank you, Dr. Abraham, for sharing the slides, and I'll be happy to take any questions. And then again, I apologize for the bumpiness of the video as I'm in a car.
Thank you, Dr. Amayu. It was awesome. It was quite helpful. I will ask, a few questions to you. I will start from myself. What AI platform is better for doctor to use, Chat GPT, Gemini, or Claude?
Yeah, that's a great question, Dr. Rafia. It really it's not as if one AI platform is better for healthcare than the others. I think the key point is not to use a free AI platform. When you use a free AI platform, many people don't, and physicians don't realize that anything you ask of AI will be shared with AI, and you are actually giving permission to the AI company to get to know you, to understand you, and develop a profile about you, and to use that data in any way that they want. That's sort of the bargain if you use a free and an open AI system. So in our organization at the FSMB, we tell our staff never to use a free open AI. We have an enterprise system. Many hospitals and health systems have enterprise systems. They would prefer that you use those kinds of systems where there's a paid subscription, because in those kinds of situations, there are guardrails in place. Your data cannot be used in ways that you don't know how it can be used. And I think that's key. For myself, I typically like to use Claude. I was using Claude Sonnet 4.6 until just the other day I met up with the person in charge of health for OpenAI, who suggested that I probably should use Claude Opus 4.7 because he said that it's much more comprehensive. And I like Claude because it also gives you the references, so that if I have some questions about the answer, I can go to the primary source and read the references themselves. But whether it's ChatGPT or Gemini or any of there's so many different tools out there. It's really a matter of personal preference, but it's important to also remember hallucinations, and there could be errors.
Yes. And then my second question, I think you already mentioned that, but is it safe for doctors to use artificial intelligence to help with the differential diagnosis in a difficult case?
Yeah, I'll maybe ask Dr. Abraham to comment as well. I think it can be. I think it's it's important that you are sensitive to patient privacy issues, that you don't share too much about the patient that you're seeing. But certainly for complicated cases, it may be helpful. But how you use that information is just as important as what you get in return. So I think documentation is going to be critical. And of course, discussing with your colleagues is always the best way to get an answer when you have a difficult case, but it can certainly be an additional tool.
Yeah, because it used to be like our curbside kind of, asking our peers and, if, our colleagues and stuff. But now if we will be relying on the AI like this, so we're going to be using this like, kind of, quite a bit. So what, Dr. Abraham, what do you think about it?
I echo Dr. Chaudhry's sentiments, agree. What he's eloquently pointed out is AI is still evolving, and they're based on large language models. So the more you feed in data, the better the tools become. And so in health, at least, that's a huge competition. All these AI companies want your information, both personal health information as well as the way you ask questions, so as to be able to better train their models to be more accurate in their predictions. So I think the caution is always that, yes, always use your clinical judgment or colleagues as well as a sounding board, because if you use just AI will always be helpful. And as Dr. Chaudhry said, there's AI hallucinations. They will come up with answers for you which may or may not be rational, including making up references that may not exist. So therefore, be very careful about believing 100% of everything you see on AI.
Sure. Thank you, Dr. So another question, if a doctor used like AI, and Dr. Hamayu, I think he said that an AI may make a mistake and a patient is harmed, who is responsible? So I think he already answered that. It will be, so yes. Okay. Next question. Is it true that AI software acting as a medical device requires FDA pre-market approval or clearance, and also requires a qualified healthcare practitioner to review and override the device or the product?
So that's a good question, because the FDA certainly has to play in the regulation of AI. I was just on a panel yesterday, the day before yesterday, actually, with somebody from the FDA. And so the FDA recognizes they have a role to play in authorizing certain medical devices, but they don't want to regulate all of AI. That's not their goal. They do have a partnership with CMMI, the CMS Medical Innovation Center, because they also are looking at how AI can be useful in healthcare. And as I explained, state regulators are looking at some experiments as well, because there's clearly a nexus to the practice of medicine as well. So a number of federal and state agencies are looking at AI, but I think the medical device piece of it is going to be continuing and critical.
Thank you. Thank you. Really appreciate that. And these are all my questions. Now we will go to our panelist. Our first panelist is Dr. Haider Alam. He is a gastroenterologist in New York. He is a graduate of Liaquat Medical College, member liaison committee APPNA since 2025, and he's very active in the committee, very supportive. And I will go to him that he can ask few questions to Dr. Hamayu. Heather, go ahead.
Thank you very much. Thank you for these talks. I really appreciate that. This is a very burning topic, AI and use in medicine, and how it will affect our future and how it will affect our education, so on and so forth. Just one comment on gastroenterology. There is endoscopy, which is being colonoscope, which is actually being used as AI, where AI is able to detect these polyps and also size of polyps and give more information. I was in a GI meeting last year, which is an October annual meeting, and they presented data. And they still feel human eye is much more better than the AI, because they were able to show multiple examples where the flat polyp was missed. AI will not find it, but human eye can find it. So I think it's a long way from where it becomes standard of care. I do use it for a complex patient, but I never mentioned my note that this is a AI-driven decision-making. It's my own decision-making. At the end of the day, I am responsible for the patient. But it is becoming more and more common to use it as adjunct to the practice, not as a... I know that this question is being answered, but I think it's important to know, and as mentioned, can it be practiced as an autonomously? And I don't think it's ready for that prime time at this moment. The second is FSMB recommend the physician only use AI as a supplementary tool, which you have touched on it, so I don't want to take your time to make it. And avoid using AI to replace medical decision-making, which again, you guys have touched on it. So I think your answers, and if you want to elaborate more on it, that would be good too. I just feel the AI will be used I think in general practice and internal medicine, gastroenterology, as a supplement and take away a lot of skirt work, which is being done by physician. I use EMR, and every time there's an update on EMR, there's more work for physician, more clicks for physician. Anybody who can't find anything, anybody else can do it, they just dump on us, which is, I hope there's the AI integration in EMR so they can take care of all these extra clicks. So I can focus more on talking patient rather than using EMR. So that's the only question I have, and some comments. And I appreciate Dr. Maya for your excellent talk.
Thank you, Dr. Alam. So definitely, I completely agree with you. I think there are definitely opportunities for AI to be used to make our lives easy, to enable us to focus on the patient, which is what we've always wanted to do. And technology has increasingly gotten in the way, you could say. So I think it'll definitely be in certain specialties more than others. For example, and you gave several good examples in the primary care fields and their specialties. I think in fields like radiology and pathology, because of the imaging involved and the convolutional neural networks. I think it doesn't mean those fields are going to go away. I don't believe that personally. I feel that AI will be used as a tool to make the process of looking at those images faster. Maybe the routine images can be looked at with AI, and the more complicated ones, for example, can be looked at by the specialists. The one area where I think AI is not likely anytime soon to make a difference will probably be in the surgical fields, because you still need the surgeon to do whether it's the neurosurgery or the orthopedic surgery, or even quote unquote minor surgeries. I think we may see a shift towards more physicians going into surgical practices, perhaps, but we'll have to see how this plays out. What I tell medical students, and I'm sure you do the same, is if you have a passion for a specialty, go follow that specialty. Don't try to predict, which specialties are 10 years from now are going to be in demand. All of the specialties are going to be needed, but they're going to be needed differently.
I just, EKG has been run by machines for the last 30 years. I understand that they can read it, but I still have to read myself those EKGs, and I see so many mistakes made by those EKG or recommendation like old MI or anterior MI and all those things. So I'm just, I think human factor still will play a significant role, especially in healthcare, because, there is patients don't want to have that kind of faith and confidence in machine than they will have with the human interaction. I just hope it's just a combination of these things rather than just one thing is taking care of all these things. So that's all I have to hope.
Yeah, I completely agree with you. When I was taught also, we were told to ignore the 12-lead
exactly.
EKG findings. Don't even look at them. But I think the challenge will be AI will give us some insight in a way that current insights are not there, and we'll have to verify, trust but verify.
Right, exactly. Thank you very much.
And still, when we are, when the question comes, are you a robot? So still we have to say I'm not a robot. So Dr. Heather, I totally, agree that, human mind, human brain, human hand still needed.
So Dr. Rafia, if I could, you bring up an important point. I'm sure everyone has seen how advanced the technology has gotten with AI. With deep fakes, you can actually
allow AI to watch you give a talk for 5 minutes or 10 minutes, and it can completely reproduce your video and your audio. And you may have heard in Pennsylvania, there was a situation where it was an AI doctor who was taking care of a patient, and the patient thought that this was an actual doctor, and then sued and said that the doctor and the company is now trying to defend themselves and say, no, this was meant to be entertainment. This was never meant to be an actual doctor. But it's hard to tell, and I think in the future it'll be hard to tell with these deep fakes.
Exactly. And thank you, Dr. Heather. I know because there's a repetition, but this is how we're going to remember all that, So please do not hesitate to ask the questions. Even Dr. Humayun has already mentioned, but this is for our, training also. And our next, panelist will be Dr. Maria Sayed. She's a graduate of Law Medical School and Chief of Rheumatology, Landmark Medical Center, Rhode Island. She is the secretary of the APPNI, the Pakistani Physician Association of New England. And she is a YPC APPNA co-lead education committee. And she will have a few questions for Dr. Humayun. And Dr. Maria, go ahead. Thank you.
Thank you so much, Dr. Rafia. And I really appreciate being part of this panelist. I'm really honored. Great talk, Dr. Humayun. I do have a few questions for you. So in terms of ambient listening technology, how, in terms of adaptability and experience, how are physicians finding that, and what's your take on it?
So great question. From what I've seen, and I've been watching this space very carefully, because I think that's the most easiest argument to make for a physician who's trying to figure out, is AI going to help me? Because many physicians, as you know, Dr. Maria, complained that when they're seeing the patient, they have to type away on their laptop. And wouldn't it be great to just look at the patient, examine them, and let someone else transcribe the entire encounter with the permission of the patient? The studies are beginning to show that those kinds of uses of AI lead to better state of wellness for the clinician, and maybe save a few minutes each encounter, and then throughout the day you don't have to spend as much what they call pajama time. At the end of the day, when you or even when you get back home, you have to still do the notes. If ambient documentation is good, you still have to verify what's written. It could save quite a lot of time. I think the challenging part is, I was at a conference last year of CEOs of hospitals, and they were talking about ambient listening and ambient documentation, and I was impressed. I thought, wow, it sounds like they support those kinds of technologies. But then one of the CEOs said he's very excited about ambient documentation because in his mind it means that the physician can see even more patients. And I remember thinking, oh, that's not the goal. The goal is not to maximize throughput, but from the business mind point of view, that is what is being talked about. So I think physicians will have to speak for themselves and speak up to make sure that if ambient documentation is used, it doesn't mean that at the end of the day you see more patients. It should mean that the quality time is greater with each patient.
Yeah, thank you so much. That was great. In terms of transparency, so we already touched about it, that patients should be informed, and there should be a consent process which should be actually implicated before even informed, treating the patient. So in terms of that, can you discuss a little bit more as to how we can actually, because this is inevitable, this is AI is our future, and we will be using it in procedures as well as documentation. So what would be the best way to inform patient in terms of transparency wise, in terms of what features are we using, and should we inform them what features and what are the limitations of AI are while treating them?
That's a great question, Dr. Maria. I think this will continue to evolve. If you remember when the HIPAA rules came out, as patients, I remember going to practices, and sometimes the front desk would give you a binder of the HIPAA regulations and ask you to sign that you've had access to it. And of course, I'm not going to be sitting through hundreds of pages in the waiting room, so I would just sign it. And then that shifted very over to, are you aware that we have HIPAA policy? Please sign here. That's not enough, because what is HIPAA? So I think for AI, the physicians should make sure that patients know that AI is a part of the practice. Does that mean you have to go into minute detail of which type of platform? I don't think that is a detail that is typically what's required, but just the fact that you're using AI is very important. There will be patients who want to make sure, doctor, are you using AI? Because I understand that I can get better care if you do. So there may be patients who want you to use AI, and there may be other patients who say, doctor, I'm happy to see you, but you have to promise me you won't use AI. Now, right now, that might be easy to do because maybe you can just turn off the augmented documentation. But there will come a time very soon when a patient comes and says, doctor, I'm happy to see you. Please don't use AI. And your response will be, I don't know if I can do that. Our hospital uses AI. Our entire practice use AI. We are not set up to use paper and pencil. So I'm sorry, I cannot take care of you because we are a fully AI practice. So that may happen as well. But the key is to make sure the patient is aware. Otherwise, there will be challenges and problems like the ones I referenced from California with that lawsuit.
Thank you. That was really detailed and comprehensive. These are the only questions which I had. You already have touch base the questions which I was about to ask. So yeah, thank you.
Thank you.
Thank you, Dr. Maria. And now I will go to Dr. Haroon Rashid. He is an MD, MPH, board certified in family medicine, graduate of Allama Iqbal Medical College. He's a medical director, Northside Family Medicine LLC, Cumming, Georgia. President, Georgia APPNA Chapter 2014, founder of Pakistani Student Association of EMRI 1989, member liaison committee APPNA. He has few questions for Dr. Humayun. Go ahead, Dr. Haroon.
Thank you, Maya. Thanks for the discussion. I'm just going to ask about the medical boards and the resources you have, especially in Massachusetts. Are the hospital systems and insurance that select tools for clinical decision support required to to educate the physicians about these tools? and provide access to performance reports and develop a process to regularly review such tools for efficiency. Are you aware of anybody working on these things? Like
So
from the
I'll answer
hospital?
for.
Yeah, sure.
Thank you, Dr. Harun. I'll answer generally, and then
No
maybe
problem.
Dr. Abraham can be more specific to Massachusetts. He's the past chair of the Massachusetts Board of Registration in Medicine. I think, and this came out in our 2024 AI guidance, we strongly advise all physicians to do everything possible to learn more about AI, both the benefits and the risks. And there are many, I get at least one email a day where somebody is offering education about AI in healthcare. Some of those are free, some of those charge money. You'll have to figure out which of those are best to do. A number of states are exploring the possibility of requiring AI as part of CME, continuing medical education, for for their licensure renewal. But many programs, many specialty college meetings. Dr. Abraham and I just went to the ACP meeting recently in San Francisco or San Diego in California, and there was lots of discussions about AI and its potential uses and dangers. So the regulators are watching this space. They want physicians to be educated. They want them to understand what is happening and to use it thoughtfully and wisely. Dr. Abraham?
Well stated, Dr. Chaudhary. Yes, I concur. So Massachusetts per se has no specific regulations around AI use, but it adopted a number of the FSMB regulations, again, about responsible use of AI and the fact that you can't, if there is a complaint or a concern or a liability claim, then the machine would not be the one, would be the physician using it who would be responsible, as they are responsible for their patients. But exactly, AI is used. You may be aware of Dr. Adam Rodman, who's at the Beth Israel Deaconess Medical Center here in Boston, who's probably one of the world's foremost authorities now on the use of AI, having done multiple research trials, involved in a lot of it, and speaks around the world on it. They all use AI. It's interesting, even medical students use AI. So at a recent presentation, he said, the people who make the questions and examinations use AI, and the students use AI. So it's AI testing AI. So I think it's rampant use, which is not necessarily bad. As Dr. Chaudhary pointed out, there are a number of advantages of the use of AI, but I think responsible use, and it should not take the place of clinical judgment. So among students, etc., we often talk about de-skilling. So when they become resident trainees in their postgraduate training or otherwise, that they lose some of their individual thinking skills, physical examination skills, etc., in the process of using AI. And in medical students, we talk about something called never skilling. So which is they've never acquired a skill simply because they've only been dependent on AI from day one. So those are things we try to avoid in its use. But otherwise, as Dr. Chaudhary eloquently pointed out, it's a problem that we are aware of, but it's also a huge tool that we can use. So I think using it appropriately with appropriate judgment is the operative term.
Thank you.
Thank you. And so anyone also has any question for Dr. Humayun? So otherwise,
Dr. Pratap, there's a question live by one of the webinar attendees, I think, says, what would be your advice for students thinking about pursuing medicine as a career? So Dr. Chaudhary is a commencement speaker and is invited speaker all over the world. So I'll defer to him for his wisdom.
Well, thank you, Dr. Abraham. You're too kind. And, you also teach medical students and residents, so I'll ask you to comment as well. So, medicine is not for everyone, the practice of medicine, but I always say that if you have a passion for it, most people do, they should definitely pursue it, and talk to their mentors that they engage with, try to see where their preferences align. It's not always easy. Medicine has something for everyone. And you don't have to be an expert in technology. You don't have to, if you like children, there's pediatrics. If you like the elderly, there's geriatrics. If you like to use your mind, there's psychiatry. If you're good with your hands and surgery, for example, I think AI will support most of those specialties. So people shouldn't be worried that AI will take over all physician jobs, but there will be adjustments made more than likely in how many physicians do you need in every single specialty. And I think, but that's I believe there'll still be a need for a physician in every specialty. And so it's important for students to keep an open mind, to also learn and educate themselves about what is happening, talk to many people, talk to mentors, talk to people who are in the field, because they're more than likely to, like the people on this panel, they're the ones to talk to because they have the years of experience and wisdom where they can look behind about what's happened, but also have the foresight to look ahead to what's coming down the pike.
Sure. Thank you, Dr. Humay. I really appreciate that. Now we're gonna move to another topic, and as we know that to relieve that the critical physician shortage, at least like 22 states now bypass traditional U.S. residency requirement for eligible ITPs and IMGs. Instead of repeating a lengthy U.S. residency qualifying, foreign trained doctors can now obtain provisional or unrestricted license by some states who are involved in these pathways. Our goal through these webinars is that if you are pursuing these pathways, you can get help for your career development, and these webinars will provide you the right and transparent information about alternate pathways working under limited license to practice in USA. We started this series of webinars to cover guidelines about evolving credentials and licensure in different states who have approved these pathways. And through these pathways, ITPs and IMG will be able to, alleviate severe workforce shortage, expanding care access in underserved and rural areas, and reducing the time and financial waste of requiring experienced international doctors to unnecessarily repeat residency training. We had extensively covered in last 4 months multiple states, including state of Oklahoma House Bill 2050, Texas Doctors Act, and today we will be discussing state of Massachusetts Physician Pathway Act. We have very respectable keynote speaker, Dr. George Abraham, Chair of Board of Director, FSMB. Dr. Abraham is a fellow IMG MD, MPH, MACP, FIDSA, FRCP London, Professor of Medicine in UMass Chan Medical School, Chief of Medicine at St. Vincent Hospital, Worcester, Massachusetts. He is board certified in internal medicine and infectious disease, Emeritus Chair, Massachusetts Board of Medicine, Emeritus President, American College of Physicians, served as a Treasurer of the Massachusetts Medical Society. So I will go to Dr. George Abraham, and he will talk to us about, Massachusetts pathway. But before than that, I will ask him that how was his journey as an IMG?
Thank you, Dr. Kutab, for your kind introduction. And more importantly, I'm honored to meet the other panelists on this webinar. It's indeed admirable to see each of them have established themselves in their fields and probably have taken the same journey. And I'm grateful to the fellowship and friendship of Dr. Chaudhry, who, even though he is not an international medical graduate, but has a heart for international medical graduates and has been instrumental in educating other US-based medical schools, institutions, and US graduates about the IMG pathway. So the IMG pathway is relatively long for all of us, as we can imagine. I had finished my medical school. I had finished a postgraduate residency in internal medicine. I taught as a faculty member, and then got married to my wife, who was born and brought up in Singapore. And so then we relocated to Singapore, and then realized that Singapore wouldn't recognize other countries' medical degrees, at least for a short duration. That left us with a mid-career decision to relocate to a country where both of us could practice medicine. And so we ended up in Massachusetts. I trained at the hospital where I currently work at, have been there for the last 30 years, and have grown in my journey. There's a lot that I've learned. I learned humility because as a intern PGY1, I was probably better trained than the PGY2 or PGY3 simply because I had 10 years of experience behind me when I was training. So it was interesting that several of them did recognize that, several of us as IMGs who come well trained really knew more. And so they were friendly enough to allow us to sometimes educate them, but sometimes be just collaborators and partners in the healthcare of our patients. I think more importantly, as all our IMG colleagues may relate to, both when we came as well as over the years, even now, is that you have to work probably a little harder to establish yourself than your colleagues who might be trained here, simply because you have to prove that you're good enough because your pedigree doesn't match the usual pathway that most people are used to. And in Massachusetts, it's probably a little more emblematic, simply because you have institutions like Harvard and others who get to pick people who are extremely good at what they do, but have often not experienced anyone else outside of the United States and that line of training. It's interesting. I'll just end with this anecdote and then I should move on to what I need to speak in the interest of time and respecting all of your time. Yesterday, on Thursday, I was at the Lown Foundation meeting. So for those of us who may not be from Massachusetts, Bernard Lown was a cardiologist who's considered the father of the defibrillator. So he was born in Russia, migrated to New York, ultimately ended up being a cardiologist at the Brigham, and he died at the age of 100. He's a Nobel laureate. His Nobel Prize, interestingly, was not for cardiology, but for something called the International Physicians Against Proliferation of Nuclear Weapons. So he was believed to be instrumental in bringing Russia and US to the table and preventing a nuclear war, and the start of the START treaties, the series of treaties that led to control of nuclear weapons. So his organization got the Nobel Prize, so he's a Nobel laureate. So he and his family have established a Lown Foundation. The Lown Institute is essentially interested in affordability, social responsibility, access to care, etc. And so they had a one-day conference on affordability. And so in the process, while I was just meeting some of the other attendees, there was this retired infectious disease physician who was a physician at the Brigham. And while we were talking, obviously he knew several people who were old-timers at UMass who I knew too because over the years. And then he said, it's sad that, now we have all these people who come from outside the country who are practicing medicine. It's a little dangerous. Obviously, he didn't know where I was from, and I didn't bother to reveal it to him. But I sort of looked at him quizzically and then didn't comment. But there is that prevalence still in thought, probably in a past generation. Probably the current generation is more aware and respectful of the fact that IMGs contribute significantly to the country. Dr. Chaudhry and I have been privileged to actually write an article about the history of IMGs. Dr. Chaudhry is one of the lead authors on that, and it's currently under manuscript review and revision, but we hope to have that published, which really shows the world of IMGs and from how history has ebbed and flowed over the years in terms of their acceptance and non-acceptance. But the fact that contributions by IMGs to, and I talk about IMGs in general, irrespective of country of origin, have contributed to research in this country, clinical care. There are specialties like nephrology and geriatrics where IMGs outweigh or outnumber the number of USMGs in that specialty, and that predominantly the larger number of IMGs are the ones who go work in rural areas, either for fulfillment of visa waiver requirements or otherwise. And so it just goes to show that this country cannot manage without, and that's sort of some of the data which I'll share with you to show. And so we do understand clearly the value of IMGs. We respect everyone and the struggle that they've been through. We respect the struggle that people encounter now. The number of applicants far outweigh the number of people who are available or who actually get positions in all specialties. And so it's a mad scramble. It's competitive. People are desperate. They invest a lot of money to come to this country. It's expensive. And it's a long struggle to get into a system where they hope to be successful, thrive professionally, personally, and with their family life. So my hat's off to everyone who's either in this or has completed this or aspiring to be. I think we definitely respect and understand clearly what all of us have been through and all of you go through. And that's the reason why we are having these conversations such as today. So with that, that sort of set up in a crux what the whole IMG journey is from a professional standpoint. All of us have been through this, taking our steps. The USMLE exam, as Dr. Chaudhry alluded to, is co-owned by the National Board of Medical Examiners, the NBME, and the FSMB. And so we primarily, as of now, we register all international medical graduates for all steps of the USMLE, steps 1 through 3. And the NBME registers everyone who's a US medical graduate for steps 1 through 3. And so clearly, we've all done that. We've gone through this pathway and then, become ECFMG certified. ECFMG is the organization that has the best access to the world's medical schools directory, as well as information about medical schools around the world. And so they're able to verify training and make sure that it is accurate and that it has been completed, and that they meet the basic foundational criteria to become ECFMG certified. And once certified, obviously we go through the national residency match, and then obviously it's if you get in or don't get in, and we can talk about any of these steps in the QA session. IMG is practiced in virtually every state in the country. Some states more than others. As you can see, there are states like Idaho, which are probably the least welcoming, or probably least number of opportunities for international medical graduates, while New Jersey has the most. And so New York, New Jersey, and the Northeast region. But in general, I think it's fair to say that both coasts have more. And but now, with increasing shortages of physicians, even the central part of the U.S. has started taking increasingly international medical graduates and recognizing their value. You look at specialties, clearly the primary care specialties are the ones which are predominantly through IMGs. And as I alluded to in some of the subspecialties, again, you see that nephrology, geriatrics, infectious disease, the less glamorous specialties are all, to a large part, international medical graduates. The quote lucrative specialties. So in the world of academic medicine, we call it the road specialties: radiology, otolaryngology, anesthesia, and dermatology. And in the subspecialties of medicine, cardiology or GI or so on, which are maybe more procedurally based and tend to reimburse better, tend to be the ones which more of the US medical graduates gravitate to. Not necessarily bad, but just goes to show that those are specialties where international medical graduates face much more competition to be able to be there, just because there are more takers for it and they are fighting for a smaller crust of the smaller section of the pie. So a few quick updates about the whole IMG process. So you may be aware there was a visa appointment pause. We are going through now a slowdown in visa processing. The ECFMG has been helpful. We have an incoming class of 25 residents who are not mainly, all international medical graduates from a number of different countries. A number of them have struggled to get visas or had visa refusals simply because they were turned down for application, even though everything is complete and they are eligible. And so it led to some intervention by the ECFMG and has led to more approvals. So this has been an ongoing issue with the current political climate in the country. The travel ban has been something which has been an issue. It happened during the first Trump presidency. It has happened again this time. The number of countries have changed. I'll show you that in a moment. But essentially that has impacted people being able to come into the country for visits, as well as down the road, even people getting immigration status. That's been a huge issue. There's something called the duration of status, which is how long the J1 visa is valid for. So technically it's valid for 7 years, but most people have been getting it, or the H1B, getting it only for 4 years. And the 4 years comes from a college, because the duration of undergraduate when our children have gone to college is 4 years. So that's where that comes from. So that sort of leaves people midway in their training. So people who finish internal medicine residency training, for example, for 3 years, are then unable to go into a fellowship, more than a 1-year fellowship, such as in geriatrics, etc., which is 1 year. But most 2- and 3-year fellowships, they get shortchanged because the visa runs out because of the duration of status issue. That's still being sorted out, as last time aware, and I'll ask Dr. Chaudhary to come in because he's as close to this or closer than I am. But we don't believe that has been sorted out yet for sure. So we're not sure where that goes. The H-1B filing fee is something we're all aware of. That's still in existence for people who apply from outside of the country and want to try to come in on an H-1B visa. That's essentially dead in the water, at least in medicine, because there's no hospital who's willing to pay $100,000 to bring somebody in, either training or for work. And there have been bipartisan legislation introduced in Congress trying to exclude physicians from that filing fee and that restriction. It has not yet gained enough momentum to go ahead, primarily because they've been distracted with all sorts of other things. But optimistically, at some point in time, that will go into effect. But till then, the H-1B is essentially something which the fee applies for anyone coming in from the country. In December, there was the additional countries that were listed in the presidential proclamation. So adding to the list of restricted countries, again, that makes life difficult for people looking to graduate and find jobs, etc., or even to come into the country. And the immigrant visa issue is what's the latest sort of insult to injury, where there are 75 countries from which people can never hope to get an immigrant visa into this country, or if they have trained here, become citizens of this country at some point in time. And so that is yet to be resolved. So just to dwell a little more, the $100,000 fee, I think we've beaten this to death, so I'm going to move on. But essentially, the big point is we've been trying to push to eliminate physicians from this category, so because there are several rural and underserved hospitals who need physicians, and most of them are people who've trained here, are IMGs, and go there on an H-1B visa. Now, if they were already here in the country, then the fee doesn't apply. But if they are to come in as a newly trained, internationally trained physician, that would be a problem. And then, of course, the travel ban. So you've probably seen this in terms of countries from where citizens can't enter in the U.S. at all, which is the Tier 1, and the Tier 2 are those who are barred from getting an immigrant petition. So unfortunately, that exists as of to date. The immigrant pause, at least, does not affect people who are on a J1 or an H1. So in other words, people coming in on training visas are not subject to that. Obviously, unless the immigrant visa pause is lifted, they may not be able to stay on to go on to permanent residence or citizenship. But short of that, they can at least train and then return to their home country or to another country. So as Dr. Chaudhary showed in his statistics, the FSMB is sort of the purveyor of the physician health census data. And that's a robust database that's published every 2 years in peer literature. But there's over 1 million people who are licensed physicians in the United States, and the IMG workforce is about 25%. In specialties such as internal medicine, it is as high as 33%. And so there is a large number, and that still does not fulfill the total number of physicians shortages that is predicted. The Association of American Medical Colleges, the AAMC, does that data. And I saw data just a week ago when we were at a workforce summit, and they predict somewhere to 100 to 135,000 physician shortages. Many states have resorted to licensing increasingly physician assistants and nurse practitioners, and they have shown, AAMC's data shows that most of them tend to congregate in urban areas. So there is now at max or a surplus of physician assistants and nurse practitioners, and rural areas are still predominantly serviced by IMGs, and there is a continued shortage. So even with the PAs and NPs entering the workforce, less so in internal medicine because that's not their forte. They love to be in subspecialties because it's very focused in terms of management and training. There still is about 57,000 plus physicians expected in the next decade, shortages expected in the next decade. So that has to be filled from somewhere. And the growth in the number of medical schools, etc., does not account or match for the projected shortage, which is why IMGs will be needed going forward as well. Dr. Chaudhary alluded to this before. The countries are the Caribbean, India, Pakistan, Philippines, Mexico. So these are the countries from where the majority of IMGs come. Not to say they don't. There are lots of other countries, as Dr. Chaudhary pointed to. So it's in the last decade or decade and a half, there's about a third, 32% growth in number of international medical graduates. Obviously, that's slowing down a bit right now because of all the visa challenges, but that will continue to exist in some fashion, hopefully will improve in the future. Dr. Kutab alluded to this earlier, the concept of internationally trained physicians. And so this was developed by what's called the Additional Commission, the Advisory Commission for Additional Licensing Models, or the ACOM as we call it. So that is, Dr. Chaudhary is the pioneer in that. So the FSMB was requested to develop some criteria around this, and they partnered, we in turn, with the ACGME, the Accreditation Council for Graduate Medical Education, which governs residencies, and with INTELT, which is the parent corporation of the ECFMG, the Educational Commission for Medical Graduates. And so together we had a whole commission, we had a group of people. I was privileged to be part of that conversation for the larger amount of time. And the commission developed a number of different criteria that could be used to develop these additional licensure models. And as you'd see, some of those criteria included, obviously graduation from medical school, completion of a postgraduate training. So this was not intended to be a replacement for the current ACGME pathway where people come fresh from medical school. This is intended to be more experienced physicians, have at least done a residency, have 3 to 5 years of practice experience, a license in good standing. The time away from practice, if somebody stopped practicing and coming in, that had to be at the minimum. In other words, months or a year or two, but not more than that. And then the intention being somebody who had stopped practicing 10 years ago, 20 years ago, suddenly couldn't be availing of this pathway to come into the US. There had to be an offer of employment, which means that either hospitals or large group practices or small group practices, somebody had to be able to offer the employment. Every state licensing board was asked to create a temporary provisional license if they accepted this pathway. In other words, a period of time when this person would be able to train before they went into unrestricted license and practice in the state. And the reason for that is because, as all of us who practice here in the US recognize, compare it to our own pathways of where we've come or from whichever countries we have come, we recognize that the practices are different, the access to care, the type of things we do, etc., all of that. And there are some things which are unique to the US, especially, practice-based licensure, in other words, practice-based pathways and practices, communication, the way we interact with patients, privacy regulations, etc., are so much different. And so these physicians may not require content training to a great extent, but they may require some of these additional other things to train so that they could be most successful when they practice here, rather than leave them in a position of vulnerability. And more importantly, the goal behind all this is to create a system where we don't create two separate tiers of practice. So in other words, somebody who's trained from here practices like somebody who has trained here all their life, the US medical graduate, and somebody who's an ITP practices a different way of practicing, but we want the same level of care and the same patient safety being assured to any patient who accessed care, regardless of what pathway the physician took to be able to practice medicine. And of course, there are a number of other criteria, but that's sort of the crux of it. From there, that was our part one, the basic regulations to get it off the ground. And then was the part two, which is, on the back end of this, how do we really assure ourselves that this person at the end of that supervisory period is ready to practice independently? And so we said there should be something like medical knowledge, patient care procedural skills, interpersonal communication, the 9 competencies that ACGME sets out for every resident who's in a GME training program. And then do some form of what we call a summative evaluation. So some sort of an examination to certify that these folks met the same standard of care, or at least knowledge base and training that somebody here who had trained from here did. And so all these are under evolution. This was an advisory commission, which meant that we didn't mandate any state to do this. And so all the states that have picked it up, about 23 different states as of today, Dr. Chaudhary can correct me if I'm wrong or misspeak, have some version of this in place. Some of these states have had it for a longer period of time, some more recently. They're still working out the details. And as best we know, about 13 or 14 people so far have been licensed in various states to go under this pathway, and they've just started. So we don't have any data for sure as to, is it work? Does it not work? Have there been problems? The states who've done it so far don't seem to, haven't reported anything as of yet, but it's yet young. The pathway is yet young. Why have there been not more states doing this? Partly is the issue of the visa. The H-1B has become a huge problem, and they need an H-1B for purpose of being able to work. And so the fee associated is an issue. We anticipate if the physician category is ever removed from the 100,000 fees requirement, then there probably can be more enthusiasm, more people might. In other 18 states, it's under active consideration. Everyone sort of views this as a potential pathway, not the potential pathway, to increase and address physician shortages. So this is one potential option, and obviously the devil is in the details and from state to state. So this is just to show you where things look. All the states in dark blue are the ones which have already adopted something. The states in light blue are the ones who are strongly considering it and have legislation in place. And there are states which are listed in white who do not have anything in place as of date. So if you were to look at the evolution of this map, you would see progressively more dark blue now than it did before. And so there is a progressive improvement or increase in this as we've seen. You notice New York, etc., and California have had some limited licensure pathways similar to this, not exactly the same, in existence for years. And so they continue to do so in their respective pathways that they've already developed. But other states are using versions of these. Massachusetts has chosen one or almost all the criteria. So Massachusetts is yet to enroll any physician through this pathway. One of the reasons for that is that Massachusetts requires, or the bill required, that it can only be a primary care specialty. So medicine, pediatrics, OBGYN, and family medicine. And it had to be through a federally qualified health center in an underserved area. And so therefore, they are still waiting for a federally qualified health center who can either meet the fee to be able to bring somebody in, and two, to develop the details of the assessment, the supervision, the assessment, etc., before they get it live. Dr. Khattab, you had a question?
Yes, Dr. Ibrahim, because you are explaining that, so all of us, we have questions prepared according that if we can ask those questions, and then you can...
Absolutely. Please do.
Sure.
Please. I'd
Yes,
love to make
that's
this
what I
more
would-
interactive than my monologue.
Yes,
So
yes, exactly.
please do.
So sure. Thank you. Thank you.
I'll pause.
So we have Dr. Haroon, who has a few questions for you in regards to Massachusetts pathway. So Dr. Haroon, if you can go ahead and ask the Massachusetts pathway, the questions we have.
Yeah, sure. First would be, is there any site for the application of the candidates in the Massachusetts system that people can apply? And do I understand that it might not be, but I just want to clarify for the people who are listening that you have to pass the exams or get your ECFMG certification. Is that the first criteria?
Yes, absolutely. So thank you for the question. Yes. So to be ECFMG certified, they have to do steps 1 and 2 and be ECFMG certified. That's sort of the off the gate. That's foundational. They apply to the State Board of Medicine in Massachusetts for licensure. But if they are going through this pathway, there has to be an employer, in other words, a potential employer here, which is a federally qualified health center, who's willing to employ the person, and they approach the state board then to say that they would be willing to take this person on, and they meet the criteria in terms of training and the visa. So once all that is squared away, obviously, if this is an offshore applicant who already has a permanent residence or a citizenship status, then the visa is not an issue. Then obviously, yes, the federally qualified health center has to commit that they will. It's a 2-year supervisory period. That's the recommendation in Massachusetts, with the option for an additional 2 years. If after the first 2 years, the candidate is not found ready to go into unsupervised independent practice, they can extend it for another 2 years. But at the end of that year, the second 2 years, they either have to be ready for practice or they won't be practicing in Massachusetts at all.
Okay.
Thank you.
And the other question is, what would be the post-graduation training they have got it from outside that would make them eligible for this pathway? Is it the spouse job? What? Go ahead, please.
Yeah, no, great question. It's interesting. That was our recommendation as the advisory commission, to say that they should have done a postgraduate, so an MD, MRCP, or the equivalent in whichever country they're coming from. So that would be considered. So the equivalent of a residency training in their countries of origin.
Okay. And how many years would be considered minimum that they will be of the practice experience they have it in their country that were eligible for them, to be considered? Like how many years it would be, uh, in other way to say they have not been practicing? Is it a minimum 2 years they need to be eligible, or after 5 years? I think you mentioned that they might not be eligible if they've been out of practice.
Correct. Excellent question. I think 2 years is a generally accepted term. Again, the FSMB has experience with this because we have published a paper on physician re-entry. So even physicians licensed in the US, if you take time off from work and then you want to come back, how much is a period of time before you say that you need to either retrain your skills or a refresher of some sort? 2 years has generally been the accepted based on good evidence from various parts of the US. So 2 years was sort of considered the recommended period. Not to say that people longer than that won't. Every state has that option, but generally accepted, I would say a safe period of time of not practice is 2 years.
Okay. And the other question would be what things they need to make look stronger on their CV to be considered a good applicant? Like what they should work on their CV.
Yeah. So in this situation, obviously, they're not competing for a residency position, so to speak. So, the traditional how many research papers you've published or whatever else work you've done or volunteer work, etc., maybe a little less of an issue. In this situation is unrestricted license to practice in their own countries. So in other words, a license in good standing, the ECFMG certification, you've done your postgraduate training in your country of origin, you don't have more than 2 years of not having worked. All these sort of set the baseline criteria. And in that situation, as long as the federally qualified health center, at least in the state of Massachusetts, is willing to employ them in that whichever specialty, internal medicine, family practice, pediatrics, or OBGYN, then they're essentially a candidate. There isn't a huge amount of competition for these sort of positions.
Okay, then. My last question is, if you want to relocate or transfer to another state, is it possible before 3 years? And would credits will be transferred to another state? Like you're working here and for 3 years you want to move to another state, would that be workable?
Excellent question. The short answer, not resolved as yet.
Okay.
So I would say at this point in time, no, because recall this is a unique pathway and the state that has granted it may not be the other state or the receiving state of the person who wishes to move to may or may not have either the same pathway, similar pathway, or no pathway. And so they may decide not to accept any of the credentials. So since this is so new, I think that piece has not been worked out as yet. So in general, I would say they're committed to the state in which they are licensed.
Oh, thank you very much,
Dr.
Abraham and Dr. Humayun. You explained things so clearly, then I think we should all have a clear mind about the future and hope that works for our international medical graduates. Thank you very much.
Thank you. You're very kind. Thank you for the insightful questions.
No problem. Thank you.
Dr. Kuttab, back to you. Does somebody else want to ask anything before we move on? Please.
I actually have a few questions. Great talk, Dr. Abraham. So my question for you is, has the board set, and this is in continuation to what Dr. Rashid has asked, has the board set any kind of criteria for measurement of professional competence, Pyru?
Excellent question. So yes, that was part 2 of our recommendation. So we talked about formative evaluation and summative evaluation. We probably all have encountered the same thing in our own respective trainings. Formative meaning things that you do, your in-training examinations in your specialties, either in your basic residency or your subspecialty fellowships. So those are where you're graded against your peers across the country. You sort of get a sense of where you stand. That's used as a marker of, can you improve yourself if you need to, or if you're already way above everybody else, then just maintain what you're doing, etc. So that is one set of things we did, and we recommended that be done at the beginning when the applicant is applying to come into the country. Why? that helps you identify the areas of need that they need supervision on. So they may be extremely smart and they may be knowledgeable in the subject matter, but your communication skills, your system based practices, those may be some of the areas they may need help with. And so, therefore, that supervisory period of training would be focused on those areas. And then at the end of it, a surrogate of a formative evaluation is a board certification, much like we've all done in our respective specialties. So ABMS is working through that right now. The American Board of Medical Specialties is working through that to develop some sort of a system where they become eligible for board certification. So they take their respective specialties board examinations and become board certified, which would be your formal summative evaluation to say, yes, this person is capable of practicing in this country and knows both from a content as well as from a system-based practices standpoint, because there are questions in the examination which cover those sort of things, including communication.
Gotcha. So if somebody is a native English speaker, do they still have to take occupational English testing? And then in terms of in-person jurisprudence examination, is there a timeline to it?
No, that would be part of the USMLE Step 1, 2, and ECFMG certification. So that would follow what people currently do in order to apply for residency, the ACGME positions in this country. So those would be part of the ECFMG certification. There is no OET or anything else outside of the ECFMG certification. Once certified you have to take all 3 steps of your ECFMG within 7 years. So that's the requirement for USMLE. But other than that, we have no additional examinations other than what I alluded to as sort of a formative assessment before they start, so we can identify areas for them to work on.
Okay. And then what is the verification process for your work experience back in your country? How's the background check? I mean, so if somebody has, how do we provide like proof of completing 3 years of postgraduate training? Is there like, we do need to provide in documentation, and the licensing entity would go and verify it?
Yeah, so the licensing board would lean on the ECFMG, and FCVS, the Federation Credentials Verification Service, which is FCVS is an entity of the FSMB. So to do what's called primary source verification. So you turn in your diploma, you have to, a transcript comes from your medical school, letters of recommendation, etc., all go directly to either ECFMG or FCVS or the local state, much like it happens now to get a license in this country. Even if when you applied for residency, you would go through the same process. And ECFMG is uniquely purposed. So even for states like, for countries like Iraq or Syria, etc., where the medical school and its records may have disappeared and candidates are unable to verify or to show evidence of having graduated, they have ways of being able to verify that. So that's why the ECFMG certification was felt to be the basic means of being able to know that these people have completed medical school and that this is a genuine, legit exercise.
And then if somebody does not have any residency or board certification, would they still be able to get liability insurance?
Excellent question. So that is completely subject to the individual carriers with which the employer works. So, you're talking about after, when they get their full license, after the so-called supervisory period?
Yes.
Okay. So yes, again, that is currently in negotiation in every state. So the highest number of ITPs have been in Illinois. So Illinois, I just spoke to their chief medical officer a couple of weeks ago at our FSMB annual meeting. And so, yes, there are self-insured programs and so on, which some of these employers use. And so they have managed to convince them to get liability insurance. So it's still so new, this is in the last year or so, that all those details are not universally worked out from state to state. But the short answer is, yes, it has happened in some states. We are optimistic it will happen in more states.
Okay. And then what are the specific medical fields is this path? Are these pathways like implemented in Mass?
So in Massachusetts, only primary care specialties. The governor signed into law specifically in Massachusetts only for those specialties, not for any other subspecialty. So the first ITP who was licensed in the country was in the state of Tennessee and was a skull-based ear, nose, and throat surgeon. So other states don't have this restriction that has to be primary care. But in Massachusetts, it absolutely has to, because it's intended to fulfill the shortage of physicians in underserved areas in primary care specialties.
Okay.
And Dr. Abraham, Maria, I'm going to add into that is that no behavioral kind of field like behavioral medicine in Massachusetts?
That is correct. No behavioral. In the state of Illinois, yes, there is.
Okay.
One of the last ITPs that were licensed was actually a psychiatrist.
So that makes a difference with the Massachusetts, pathway than the other one because in the Texas, the Doctors Act, and the Oklahoma, they are covering the behavioral.
That is correct.
Okay.
That is correct.
Thank you for correcting that. Go ahead.
I just have a couple more. So in terms of primary care, it would imply both family medicine and internal medicine, or it would be...
Correct. That is correct. So the 4 primary care specialties in general that we consider is family medicine, internal medicine, OBGYN, and pediatrics.
Okay. All right. Thank you so much. That was really helpful.
You bet. Thank you for the questions. You were great. Dr. Khattar, back to you.
Dr. Maria, that was great. Awesome questions. Now we have Dr. Heather Alam, who has few questions for Dr. Abraham. And
Sure.
Go ahead, Dr. Heather. Did I mute him? Oh, let me.
I got it. Okay. All right. Thank you. Thank you, Dr. Ibrahim, for giving such a great lecture and, clarifying these things. You were so clear. So I have a few questions. One is about visa for work authorization. Do I need a visa to get the job, or first I get the job and get the visa, or I need to be legally authorized to work in USA? How is for the pathway? How does it work?
Yeah, for a non-citizen, they will need a job to be able to get the visa, because the H-1B is an employer-dependent visa, which means the employer applies for the visa on behalf of the applicant. And so therefore, if you're coming in on an H-1B, the employer, that's why the employer has to pay the $100,000 fee as well. If you're a green card, which is a permanent resident or a citizen, then none of those visa regulations apply.
About the offer from employer, can you give us some criteria for the employer? What kind of employers can actually offer these jobs?
Yeah, great question. It's so totally variable from state to state. So I'll give you an example. So in Massachusetts, it has to be a federally qualified health center or entity in an underserved area. So that's why there's a holdup for now. No federally qualified health center has the financial wherewithal to be able to attract people from outside the country, even though they need physicians badly. But in the state of Illinois, for example, one of the ITPs is someone who's working for a series of dialysis centers. So there's an entity that owns a whole lot of dialysis centers and brought this physician in to be a physician to all the dialysis centers. And so they offered the H-1B and they paid the fee, and they pick up the malpractice as part of their self-insured. And so that would be one potential employer. But there is no restriction on who the employer could be other than in the state of Massachusetts. So it's variable from state to state. But so any entity that's willing to, one, employ them, to pay the fee to bring them in on a work visa if they're a non-citizen, and number 3, to be able to offer liability insurance, then it's basically a go.
So you have some experience that some of the employers have been able to pay $100,000, though it's not very common and people can't afford it.
That is correct. Yes.
Does the job offer need to have a signed offer for full-time employment to operate in this kind of setting?
Yes. So full-time employment that's a condition of the visa, to be candid.
There's a question about do they have to work under or supervised by a department chair, or is it necessary?
Excellent question. So, that was one of the things which came up for significant discussion when we were putting that forward as a potential recommendation, was that, who supervises these people? So could it be an individual physician in solo practice in a rural area, or could it be a small group practice? The general feeling was it had to be a large enough entity who had experience with supervising residents, and to be able to supervise such trainees, because this requires extra time, extra effort, etc. And somebody who knows or who is in the practice of supervising and evaluating trainees. And so while it's not specified or laid out who that entity should be, the general accepted recommendation is that some sort of an entity that can supervise them or is in a capacity because they do some sort of supervisory training. And that's up to the individual state board to implement what details would be required to make that determination.
And I have to add one thing into that is that the structure, how all our residency program, they are structured, that we have health centers and we have one chair, or we have the director. So probably that in the fine writing of this, that they have to work under these like a chair or the chairman or the director, that how that we work under as resident under these directors and chairmen. So I think that would be we are talking about that.
That is correct. That is correct. A program director equivalent or a department chair, yes, much as all of us have done during training, residency, or fellowship. Yes, exactly. Somebody who has the ability to evaluate and to ensure that this person is meeting the required recommendation, because that's the person who's signing off to say this person has met all the criteria and is safe to practice independently.
Sure. Go ahead, Dr. Heather.
So after doing my 3 years of under restricted license, how can I get the full license? How does it work?
So
do I need to continue working in the same environment, or do I change my environment and go somewhere else? And how does it work?
Excellent question. So the two criteria to that. So the I'll use Massachusetts as the example. So if somebody were to be working under this, they would get a provisional license, and that's pretty much what every state grants under this pathway, is what's called a provisional license, which means they have to work in the specified setting they were employed for at least 2 years. And subject to, after 2 years, if they have done well, then they get what's called a full unrestricted license, which allows them to practice anywhere in the state. So the license will not be restricted at that point in time. Obviously, employment offer and all the rest will be subject to either visa requirements, or if they have gotten permanent residence, then obviously none of that is a factor, but they'd still be within that state. The interoperability of the license, which is from state to state to be able to transfer, is still not completely worked out yet. And so at this point, I would say that option may not be on the table, but maybe in the future.
And can you highlight some of the major barriers which are to adopt this alternative pathways?
Right off the bat, the visa is the first issue, because the larger majority of folks who might want to apply through this are non-citizens, so which means non-US citizens and non-permanent residents. So that's a huge deal breaker. So coming in outside of the country, the number of employers who are willing to pay the $100,000 fee is virtually negligible to nil. And so that's why that's a sort of the basic non-starter. The second piece in this is just finishing all the ECFMG certification, finding the offer of employment where they can not only get to work, but get malpractice insurance, be credentialed on insurances. So you and me and all of us are credentialed with various insurances to be allowed to see these patients and be reimbursed. That's another piece that's still being worked out. So not every state uniformly has accepted. There are a couple of insurers who have, others who haven't. Medicare and Medicaid are a challenge from that standpoint. So there's lots of those pieces that need to be worked out, which are all potential barriers right now. Not insurmountable, but definitely potential barriers to this being a more widespread and more robust system.
Just the last question.
Sure.
In your opinion or in your experience, what percentage of people have applied, and what are the, what have been successful? What is the experience they have? How many you think have totally worked well, and where are the failures? And, just to some hint about optimism for the people who want to use this
absolutely pathway. No, excellent questions. Only about 13 people that we know so far. So it's not that people are banging down the doors as yet, not because there's not an interest in this from outside of the US, but primarily the challenges of working out the visa and the employment and the malpractice and the credentialing requirements, which have been sort of a barrier. I would say that let's look at two different scenarios. So number one, New York and California are exceptions to the rule, and I'll address those in a moment. But all the other states who've implemented this pathway, many of them, including Massachusetts, have had zero applicants as yet because this is sort of driven by the employer. So the employer has to be the one initiating this process. And so as yet, they have not worked through all the issues of the liability issues and the credentialing issues and getting payers to accept them, etc. So this is relatively new. So we have no stories of failures once they have started as yet. Probably because it's so new and it's sort of so low key that no state has reported a failure of a physician who came through this pathway. That said and done, the successes, as I alluded to, about 13, and so very small numbers to make any good generalizations as to the success or lack thereof. We addressed already the challenges that we talked about. Briefly, let me address New York and California. So New York has had a variation of this pathway in place for years. And New York basically has no strict defined criteria such as I laid out before earlier. And so they have hired anywhere between 20, 30, 40 in any specialty. So they view it as a need-based application. So as we spoke to the New York City health director, and they said, I need a pediatric neurosurgeon for my city-based hospitals in New York. I will go out and find a person and I will hire them and I'll bring them through this pathway. And that is it. They are hired. So New York has a very unique pathway. In speaking to New York State Board and asking their experience, they claim almost universal success. As you and I know, there are always people who struggle in the practice for one reason or the other. So it's not that every person whose license is 100% successful 100% of the time. There are challenges. So they have similar, but they state it's sporadic, and that well over 90%, if I were to attribute a number to it, are successful. So they have no qualms about the process, and they seem to stand by it solidly for the last several years, and that seems to be the easiest. California has had the similar process in place, but strictly located to Spanish-speaking areas. They bring in 30 Mexican physicians once a year, every year, to address Latinx areas which need Spanish-speaking physicians. And they also claim universal success with their program. But recall, that's just a narrow ethnicity and linguistic category that they use. So that has been their history. So that's sort of where this is across the country. It's a very varied from state to state in terms of criteria, in terms of access, in terms of success, all of the above. So that's why I wanted to give you a flavor, because the person applying needs to shop all over, and the shopping may be very variable in terms of results.
Thank you.
Thank you, Dr. Ibrahim. This was really very, kind of putting the light on this, that, there are so much hopes, there are so much, enthusiasm about it. And people are thinking that there you go, now there are pathways and we will be going to, USA working as physicians without the residency. There's a lot of promise there.
But right. Yes. I mean, everybody is trying to reach the promised land, so to speak.
Exactly.
Or at least was the promised land.
Yes.
I see Heather smiling, but yes. We were all that way, right? When you go back home, everybody thinks that, you're the affluent relative who can afford to fund all the housing needs and every other needs. I get it. I get it. Our relatives all live in poverty in different parts of the world.
Exactly. The story of everyone.
You're coming from the US. You're the affluent guy. Come on, you can afford to pay us some money, so on. Yes, I get it. I relate to that completely.
Trust me, Dr. Ibrahim, I envy them, because the facilities and the things they have, we cannot even afford those,
Oh, completely agree. Plus, they don't know that here on weekends when you're on call, you're busy still doing your groceries, your laundry, your gardening, your shopping, all the rest of the above. And there's only you. There's nobody else who's going to do that for you.
No
right?
one.
You don't
and
get
driving
labor,
and on top of that, driving in the snow, 5 a.m. in the morning, 4 a.m. in the morning.
Completely
and
agree.
Then we have to pay all the taxes, which is really
true.
Yes.
Welcome to Massachusetts. We call it Taxachusetts.
Exactly. So, Dr. Ibrahim, I have this question. What do you think? What is the scope of these pathways?
Excellent question. I've thought of that same question multiple times. Especially, I'm a little disheartened by the fact that this has not picked up speed. Not for lack of interest, even by state medical boards or so on. I think all these other barriers, so this is where I was alluding to, for all of us who've come through this pathway, we recognize that the challenges that we've come through are not something that people who've trained in the US have experienced. They don't understand, and they're not willing to sometimes take those extra burdens on in order to get this one person in from the outside. So that's sort of been the hindrance. So unless we open up some of these barriers and unless we eliminate some of these barriers, this program will sort of smolder along, but it will not become a raging fire in terms of it will still not be, which is why the larger majority of our applicants still go the conventional ACGME route, simply because of this. I just put up my last slide here is Canada. So Canada, interestingly, has had a similar program. It's only 12 weeks. 12 weeks. And then they do a workplace assessment. If some people are ready, then they put them out there, especially in rural areas. And I've spoken to the CEO of the Medical Council of Canada, and asked him about their experience, etc. They have an experience of about 1,200 physicians who've gone through this pathway already.
In 12 weeks, just 12 weeks.
In 12 weeks, yes, that's all. They require 3 months. That's it. That's all they require. So that's, reflective of the paranoia in the US that, oh my goodness, how could we, let them lose after 3 months? Yeah. They won't have learned anything, blah, 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 right? Does it ring bells to all of us who've been through the same pathway? Yes. The assumption is you're coming with no modicum of knowledge, you don't have basic sophistication. You're coming from somewhere in the middle of the unknown. And so that's the barriers we are trying to overcome in this process. And unless we all speak up about it, and unless we constantly champion this pathway, that will continue to struggle. Because if Canada can do it in a far less time frame, nobody's dying in Canada because of this. Granted, they have said there are occasional failures. I mean, as we said, every person is different. This is not like a factory made that everybody comes out with the same qualifications and the same credentials. But their successes far outweigh their failures, and their process is way shorter, and their people do well. They've addressed their rural-based needs far better than we've been able to.
And Dr. Brett, if I'm not wrong, they have taken the idea from us,
Absolutely. No, they were part of this commission. Yeah. They were part of ours. So yes, they picked it up from us for sure.
Exactly.
Yes. Yeah. Heather, sorry, you were going to ask something.
Yeah, I was in Calgary a couple of years ago. And there are actually primary care physician, family medicine physician who are trained in UK. And there are multiple of them, like maybe Pakistani. I know Pakistani, there are 200 Pakistani physicians. They just moved there without any retraining or any exam. They just had few years of experience. They showed their experience and they had no problem. They are practicing well. They are big practices. They're taking care of needs. So I think, maybe the problem is about how to refine this and make it a better program, which everybody can understand it and sign on it. And it will take care of a lot of needs. I mean, I'm in a rural area, and I know if two physicians more goes from there is no healthcare. There's no doctor. It's only PAs.
Exactly.
And that's not the care you want. I don't want that kind of care. Why would I ask my patient to take care of that care?
Precisely.
So it is
right.
major issue.
And notice for most of the folks who are applying like this, the examinations are not a barrier. They're used to examinations all their life, right? So examinations are not the barrier. It's the other red tape that occurs in the US, which is it's because culturally
they're like not a paranoia. It's
the paranoia that we are some exclusive breed that requires some highly sophisticated, highly skilled and trained people only that who can take care of us, so to speak. Yes.
And so actually we are. Actually we are.
Well, yes. I mean, to stroke our ego, we could definitely say that. But at the end of the day, we're all still human beings like everybody else. We have the same illnesses and the same weaknesses and the same values. So I think, this is great. You're having these sort of conversations. You have superb leaders like all of you on this panel. Please use every opportunity to champion it, much like this is exactly what I do. So I was at the American College of Physicians less than a month ago. We did this whole presentation. This is the first time ever that they've had a session talking about IMG issues and ITP issues and so on. So we say wherever I get an opportunity, we speak about this simply because the more people we can sensitize to it, the more people can learn and become acceptable. and more importantly, that we
Desensitized.
can champion this cause.
Yes, yes.
Yeah.
And Dr. Ibrahim, I have just quick few questions before we end. And
Please.
I was waiting for you that, knowing you for like since I am in Massachusetts, and seeing you, the other day I was talking to Ghazala Faraki and she was like, oh, we did the residency and all that stuff. So, Massachusetts has its own culture. And, I'm very happy in that way that practicing physician over here did my residency UMass and working with you in the, St. Anne's. So my question to you would be, what made you to involve in the free clinic and what is your message to all the IMGs or the medical students that going to these free clinics and getting the experience and getting some kind of letters, and helping the community? What is your message on that?
Yeah, excellent question. So I think the concept of the free clinics, and I'm sure each of us on this panel volunteer our time in one way or the other, but that's to allow people to access medical care who otherwise would have no access to medical care. And I'm sure we all relate to that, given where we've all come from. You raise an excellent couple of questions, Dr. Kutta, which is one, should residents be doing that? So in our residency program, for example, we have 75 residents in internal medicine. We were making them. That was part of one of their required rotations to go work in the free clinic, because they would learn inequities to care, which they don't experience when the patient is in the hospital. However, ever since the ICE enforcement and the fact that people are wandering around, our residents became increasingly uncomfortable because they don't walk around with their passports and their visas all the time. And so we temporarily suspended the program simply because this has become the stumbling block. So we still see patients, but obviously some are people who are undocumented. To us, it does not matter at all because they still need care and we will provide the care. But they are afraid to seek care in more established settings simply because of all the other inequities. So I was alluding briefly to the Lown Foundation Award meeting that I went to. So they have an annual award called the Bernard Lown Award for Social Responsibility. They've done it for 5 years. Interestingly, all the 5 recipients are all women physicians. And this year's award went to a lady called Dr. Chanel Diaz, who works out of New York. But she basically goes into all the ICE detention facilities to take care of the people who are held there in ICE detention. It was just amazing to hear her speak of the stories of people and what they go through. These are people just picked up from the streets at random, just when they were going to do routine chores or going to work or something else. And then they're in this detention with so many other challenges, which I won't ever diverge into. But the point being, these people have no social connection, no family connection, no access to care. And so, my hat's off to people like them. So we all need to do that as part of our calling as physicians. So the short answer is yes, it's useful to do that, not only because we want a letter for our career needs, but just because it's a good thing to do. But that's the reality also, is that we deal with a climate where not necessarily all good deeds result in good endings.
And my last question, I think I am so emotional right now while you were talking about it. And it hurts all of us. And
Yes.
plus it is hurting the communities because all those, I remember those times, St. Anne's, we were all like so involved and helping our communities and all. And proudly telling you, remember that Dr. Claremont, Dr. Jane
Yes.
Lokri, Dr. Jane Lokri, you and everyone,
Absolutely. Yep.
those were the times, it was. And so my last question, is that, do you think that really these IMGs who are applying for the residency, they need to do an observership over here?
So my short answer is twofold. So we had a summit on whether observerships are a value or not, led by ECFMG, ACP. There were people from across the country, including all the academic community. The short answer is there's been such a race to these observerships. And so here's the hazard. First, so my personal opinion, and in our program, we don't require it. We don't encourage it because these observerships have become an issue. Because they have become actually a predatory market.
Yes.
I won't name areas or physicians, but we have physicians who charge $5,000, $10,000 to these poor folks who have probably mortgaged their entire possessions to rumble up the money to come to the country, stay here on their own expense, and then pay. And then they go for like a half a day, 3 times a week, because the other half day, there's another cohort of people hanging around. And so it's just totally, and then they get a standard letter, which is the same verbiage. They just change the name of the applicant and the same letter gets churned out to it, which is meaningless. So most program directors do acknowledge it is of no value from that standpoint. What's more worrisome recently is that a number of these folks who've gone for observerships have been denied their J1 visas when they apply to get their visas, because the consulates have what's called a foreign affairs manual. And in that, they have said this has to be shadowing. And so they start asking the applicants, so what were you doing in your observership? And they'll say, oh, we used to work up the patient and then go present it to our attending. They'll say, oh, that's a violation of your visit visa, your B1 visa. Your application is denied. So there are several such reports, including most recently in the cohort who's applying this year to come in for the July 1 start date. So, we have been strong fans of saying this is a predatory market where people are just being fleeced for their money, nothing valid in return. More importantly, they threaten their ability to come back here for a training visa, because these consulates have gotten increasingly rigorous about that, and they ask questions, and for people try to get helpful by saying, oh, I did this, I did that, and trying to impress the consular officer, and they just jeopardize their visa interview.
And Dr. Ibrahim, Dr. Heather is here, and I will talk to you about one very painful webinar we did last year, that one of the observer who was here from Pakistan cleared all her boards, and she was doing a observership, and she got so sick, but she was so scared to ask that, like she's sick and she needs time off, and she ended up dying, So that shook us, all of us, did a fundraise for her, but we couldn't save her. She needed a liver transplant and stuff. But since then, I am on it. Like, one thing is this, yes, opening a can of worm about exploitation through financial. Their parents are, taking loans, selling their properties and sending them over here just for an observership. But the second is the other kind of exploitations also, and when
Absolutely.
And they get exploited, and then they are scared to ask for help, and they don't know where to ask for the help,
Precisely. Exactly
So,
right. So this is being studied vigorously. There's already data where program directors admit that this has not influenced their decision making as to when they choose a candidate, whether they've done observership or not. This has become sort of, and when 5 people do it, the next 5 people want to do it because they say, oh, they've done it and I haven't, maybe my application is going to be inferior. So you're exactly right. This has set up this rat race where everybody is saying, oh, if I don't get an observership, I don't have a prayer of getting a residency. That's not true. I didn't do any observerships when I applied to this country.
I didn't,
Yeah. So, I think that's the other. So I'm a strong proponent of this sort of exploitation of, poor, innocent applicants who don't know better is really unconscionable. That bothers me a lot.
Exactly. And this is exactly what remind me of that one night when my 3 kids, going to high school, and they need to have all these APs. They need to be all-rounder. They lost their childhood,
Yes.
We didn't enjoy them because we were in that rat race.
Yes.
That they have to be in a certain college. They have to get this scholarship. So we lost all that, the whole happy family kind of. We were so overwhelmed that how they can get into a research, how they can get into a sports, how they can get into a debating society and stuff like that. So they can be an all-rounder,
Agreed.
It is so painful, the process, making of a star. It is like, if you have remembered that movie,
Yes.
making a star, like it's so painful.
Yeah. Couldn't agree more.
This whole process, and then we cry about burnout, then we cry about suicide prevention, we cry about behavioral issues and stuff, but we are creating all that stage for them.
Amen. Yep. Couldn't agree more. Eloquently stated.
So that's where I am, that why I get you guys on board, why I want you to convey the right message to these young people, that this is not the end of life. And there is hope, there is help, but you need to be in a right state of mind.
Couldn't agree more at all. Couldn't agree more.
I am so thankful for all of you guys. I get emotional about it, but since that incident happened, but Dr. Ibrahim, that, not one more, that's how I think, So I am so thankful, you guys being here. As in the beginning, I said to, the McGovern, Congress, I talked to him personally and I said, my heart cries for it. Like, why we need to pay this 100,000? Why we cannot have these doctors over here when, there is no doctor? So, and I am so thankful to him. He listened to it, he signed it, this is what we need. You go to AMA, I go, we raise our voice there,
Yeah.
And this is what we need, at least to that level, But I have to say, in the end, you are always like, we always look up on, like, at you, like, hey, you know what? He is a mentor, and we really Massachusetts is very, very lucky to have you.
Oh, thank you. You're very kind.
Yeah, it's a long time. It's not just today, it's a long history there. So I'm very thankful. Thank you guys bearing this time with us, and we will conclude it this over here with this prayer and with this wish that there will be better days coming.
Great. Thank
Yes,
you. Thank
for
you to
all.
each
Thank
of
you
you
very
for the
much.
generosity of your
It was
time and your
wonderful.
Thank you very
expertise.
much for your time and education. I appreciate it.
Thank
Thank
you.
Thank you.
Bye.
Thank you.
Bye-bye.
Bye.
Bye.